Welcome to Learning Plan 9. We are going to be covering endocrine medications and the endocrine system, more medications than the system. We're going to start off with diabetes, though. Diabetes is such a major problem, and I want to make sure everybody understands how we treat this and why we treat it the way we do. Diabetes is an imbalance of several hormones and parts of the pancreas. The pancreas creates actually two different hormones. You may remember this from anatomy and physiology. It creates insulin and glucagon. Insulin is created by the beta cells of the islet of Langerhans. Glucagon is secreted by the alpha cells of the islets of Langerhans. Glucagon and insulin balance each other out. And in a person who has no problems with blood sugars, it's a constant balancing act. In type 1 diabetes, the destruction of the beta cells in the islets of Langerhans results in no insulin secretion. Type 2 diabetes is also sometimes called maturity onset impaired or adult onset diabetes. This is a slowly developing disease in where the tissues lose their sensitivity to insulin, developing insulin resistance, and ultimately you need additional insulin to properly transport the glucose into the cells. Diabetes is the 7th leading cause of death in the U.S. There is no cure. There are treatments to control and manage, but currently no cures. Search for cures is ongoing. Much of the search is utilizing stem cell transplants, but so far nothing has been found. There's also gestational diabetes. 4% of all pregnancies have gestational diabetes. And if you have an elevation of fasting blood glucose beyond 126 on 2 separate occasions, that is diagnostic of diabetes. But let's talk real briefly about the balancing act between insulin and glucagon, because that will come into play with the medications we give. The pancreas puts out both of those hormones. When there's high blood glucose, the pancreas puts out more insulin. The insulin stimulates glycogen formation within the liver. It pulls the glucose out of the bloodstream into the cells. That's what insulin does. It pulls glucose into the cells. When there's low blood sugar, the pancreas realizes that your body needs more sugar, so it puts out glucagon. Glucagon stimulates the glycogen breakdown within the liver, which puts more sugar into the system. When there's more sugar in the system, the pancreas says we need more insulin. And that pulls the sugar back out of the system, where the pancreas then says we have low blood sugar, let's put out some more glucagon. It is a continual cycle of insulin, glucagon, high blood sugar, low blood sugar, back and forth. When it works, it works. When it doesn't work, diabetes is the result. So what does insulin do? Well, insulin helps lower blood sugar. That's the long and short of it. It transports glucose across the cell membranes into the cells. Without insulin, sugar does not get into the cells, and the cells will starve. And one thing to remember, your brain only operates on glucose. Insulin also converts glucose into glycogen. That's how our body stores glucose for future use. It stimulates lipogenesis and inhibits lipolysis, or the breakdown of fat into fatty acids. So it stimulates lipogenesis, meaning the creation of fat cells and fat stores, inhibits the lipolysis or breakdown of those same cells. And it stimulates protein synthesis and inhibits protein breakdown. So when you have enough insulin, you are pulling this glucose into the cells. you are converting glucose into glycogen, which is stored energy. You're also stimulating the formation of fat stores, and you are stimulating the synthesis of proteins. That's what insulin does. What does glucagon do? Glucagon helps raise blood sugar. It converts glycogen into glucose. It stimulates the breakdown of fat, and it stimulates the breakdown of protein. So they're exactly the opposite. And you need to remember what those are for, because later on we're going to be using both insulin and glucagon in terms of diabetes management. So the normal response to nutrient intake when you eat carbohydrates, it causes your blood sugars to go up. That's your pancreas says, hey, we have a lot of sugar in our system, dump out some insulin. If the insulin keeps getting dumped out, you develop hypoglycemia, which inhibits the further insulin release. A normal blood sugar is 70 to 100. A normal fasting blood sugar should be 70 to 100. Now, in diabetes, this is a complex disorder. It's a disorder of carbohydrates, fats, and protein metabolism. It's caused by the lack of or inefficient use of insulin in the body. You've heard the phrase insulin resistance. That means your body has insulin, but the cells just don't recognize it. Now, what is the criteria for actually diagnosing diabetes? You must have a fasting glucose of more than 126 on 2 separate occasions, or an hemoglobin H1C of greater than 6.5%, a non-fasting blood glucose of 200 or higher, or a glucose intolerance test of 200 or higher. So those are the various ways diabetes is diagnosed. Long-term consequences are profound and important. You could develop coronary artery disease. Cerebral artery has the macrovasculature, let's call it that. Coronary arteries, cerebral arteries, and peripheral vessels can become atherosclerotic. In the coronaries, you develop a heart attack. In the cerebrals, you have a stroke. Peripheral vessels, you get peripheral vascular disease. In the microvascular, the very small vessels, you can develop retinopathy within the eye, developing complete or partial blindness. You can develop neuropathy, automatic and somatic nerve dysfunction. And you can develop nephropathy, which is chronic renal failure. All of those are terrible. They're what results in people going blind, kidney dysfunction, amputations. So we want to control as much as possible. So the ABCs of diabetes. A is for the hemoglobin A1C. Hemoglobin A1C is used for long-term diabetes monitoring. It does not tell you on any given day what their blood sugar was. So it cannot be used to decide how much insulin to give today. But it says what they've been doing over the long period of time. B is for blood pressure. When you have diabetes, you are at risk of high blood pressure because of the atherosclerotic effect and plaque buildup within the coronary arteries. C is for cholesterol or dyslipidemia, again building upon the problems with blood pressure and diabetes. Diabetes is a major risk factor for heart disease. So if a person is diabetic, you need to monitor and control blood pressure and cholesterol as well as blood sugar in order to provide the greatest overall health. As the hemoglobin A1C rises, which indicates worse control over the long term, the risk of the various conditions greatly increases. On this chart, you see that under 7 and pretty much everything has the same amount of risk. But once you start getting beyond 7, the risk of retinopathy, the microvasculature, rises greatly. That's why vision changes are so profound. Blood testing. We do blood testing at the bedside. We do blood testing in the lab. The hemoglobin A1C, or the glycosylated hemoglobin, that's done in the lab. A normal range is 4 to 7, less than 7%. If a person has poor diabetic control, you're going to see greater than 8%. A person who's diabetic will be tested 3 or 4 times a year. Blood glucose testing, BGTs also called. This is from serum or capillary samples. Serum meaning a venipuncture, capillary samples, fingertip. 70 to 99, good control, and that is everyone's goal. The goal is under 100. 100 to 25 could be prediabetes. Over 126 on more than 2 occasions is diabetes. When you're looking at hemoglobin A1Cs, again, these are used only for long-term consideration. But they do give you an idea of what the average daily amount is. So if a person has a hemoglobin A1C of 7, on average, their daily BGT would be about 154. That's poor control. So that's what these are for. Again, it does not help you decide how much insulin to give today. But it may tell the doctor that another form of treatment is needed to be added to their treatment regimen. Everyone has their own glycemic goals, just as everyone has their own goal for everything. A reasonable A1C goal for non-pregnant adults is less than 7. However, if a person is diabetic or at risk for it, they may want to set a goal a little bit tighter, maybe 6.5%. If a person is older, if they're elderly, or they are, let's say they're terminal, let's say they're on hospice, then the hemoglobin A1C goal might be much more than 7% or maybe no goal at all. Everything in nursing and medicine is individualized to the person. We can give all these generalizations, but we don't treat generalized people. We work with one person at a time. So we have to look at that person, that person's situation, where they are in life, what else is going on, to determine what a reasonable goal is. And that's how we treat everybody for everything. So come back, we're going to talk about the specific types of diabetes now. This is just a generalized look at diabetes and the role of the various hormones. Let's talk about the specific types in Part B.